Hi, Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. For many years, there was a great deal of controversy about whether premenopausal women with early stage breast cancer should undergo ovarian suppression or ovarian ablation with oophorectomy. And we just didn't have level 1 evidence from prospective phase 3 trials until a few years back when we got the results of the SOFT and the TEXT trials that were analyzed individually as well as with a combined analysis of the LHRH agonist plus tamoxifen versus LHRH agonist plus exemestane arms of the trial. The LHRH agonist that was utilized in the SOFT and TEXT trials was triptorelin. And the design of the SOFT trial is a 3-arm randomization, and patients could have received prior chemotherapy, but they had to have resumption of menses or a resumption of ovarian function such that premenopausal estradiol levels were found in the plasma. And so they were randomized in a 1-to-1-to-1 fashion to tamoxifen alone versus tamoxifen plus triptorelin versus exemestane plus triptorelin. And so they were documented to have had resumption of their ovarian function. The TEXT trial was largely conducted in Europe. It was designed in Europe, and it took a different approach. The Europeans have been long-standing advocates of ovarian suppression in premenopausal patients. And so they did not want to randomize patients to no ovarian suppression. So all of the patients received triptorelin. Interestingly, they started the triptorelin from day 1 of adjuvant chemotherapy for patients on the trial. All patients, if they received chemotherapy, they did not have to receive chemotherapy, but the majority of patients did receive chemotherapy. So the patients were randomized to triptorelin plus tamoxifen, and the tamoxifen did not start until after the chemotherapy, or triptorelin plus chemotherapy followed by exemestane after they finished the chemotherapy. So that's really the only data we have that's very robust that shows us the outcome of patients who receive an LHRH agonist along with the curative chemotherapy. It is very helpful to have that information. So because in the SOFT and the TEXT, both trials had an arm of the triptorelin tamoxifen versus triptorelin exemestane, they were able to do a combined analysis of those 2 arms, which gave a great deal more power to the analysis. And then the SOFT trial had the tamoxifen alone arm. And what has been found both at the 5-year analysis and then subsequently an 8-year median follow-up analysis is that for low-risk women, those who for example, did not receive chemotherapy, or for patients who did not have any adverse high-risk features, which I'll talk about here in a moment, then in those patients, there was no benefit of the addition of an LHRH agonist to tamoxifen or utilizing the exemestane and the triptorelin compared to tamoxifen. This was the very lowest risk patients. Conversely, on the other end of the spectrum, patients with the high risk features had a great deal more benefit from the combination of exemestane plus triptorelin. And this is very interesting because the patients stopped their endocrine therapy at 5 years. And then the follow-up at 8 years, the patients were off of the endocrine therapy for 3 years. But the curves stayed pretty much stable. There wasn't a great deal of decrease in disease-free survival in the patients after they stopped the LHRH agonist and tamoxifen or the exemestane or tamoxifen alone. It's going to be very important to see additional follow-up to see whether over time patients' outcomes become worse stopping the endocrine therapy. And it gets to the issue, which I'll talk about here in a second, of the duration of endocrine therapy. From this SOFT and TEXT trial combined analysis has come a very important evaluation of who needs tamoxifen alone, who needs the exemestane and triptorelin, and who can do well with the triptorelin plus the tamoxifen. And there was a very in-depth pathologic and histologic evaluation of the tissue samples from this trial, all done centrally. And the Dr. Meredith Regan, who's one of the chief statisticians on the SOFT and the TEXT, and her colleagues have done a very in-depth analysis of these risk factors, trying to ascertain which of the endocrine therapies was most beneficial for which women. And the factors that were evaluated were age. So under age 35 was an automatic high risk factor, tumor size, nodal status, grade, progesterone receptor status, and Ki67. And for each of these, and the estrogen receptor, the strength of the estrogen receptor. So, for example, there were buckets of estrogen receptor positivity, progesterone receptor, and buckets of Ki67 staining, et cetera. And these were all centrally evaluated. And the greater the number of high-risk features, then that's called the composite score, all published by Meredith Regan in the JCO a couple of years ago, then the higher the risk overall, and the greater the differential benefit from exemestane plus triptorelin compared to triptorelin tamoxifen compared to tamoxifen. So the higher the risk, the greater the benefit from exemestane. And one of the key drivers of that risk is proliferation. A previous trial in postmenopausal women, the MA17, with centrally evaluated Ki67, showed that for women with high Ki67, and it was defined as above 20%, there was a greater differential benefit from the aromatase inhibitor, in this case, letrozole, compared to tamoxifen. So the higher the Ki67, the more likely it is the woman will benefit from an aromatase inhibitor compared to tamoxifen. And young age, in the SOFT and the TEXT analysis, patients under the age of 35 did very, very poorly with tamoxifen alone. They really require triptorelin, and generally that's a high-risk feature. And if they have any other associated high-risk features, then they do benefit from an aromatase inhibitor compared to tamoxifen. And this JCO paper by Meredith Regan is very well worth looking at and really studying, because there are tables that show the impact on risk and on outcome with tamoxifen versus tamoxifen, triptorelin versus exemestane triptorelin, based on each of those high-risk features, looking very granularly at the delineations in each of the high-risk features to help us see the impact of those on outcome. Very, very important. So you can get a sense for which patients are highest risk and should be treated with an aromatase inhibitor. So the second question is how long patients should receive endocrine therapy for. And here we turn to the NCCN and ASCO guidelines, which have really tackled this question several times. And what's recommended is that patients receive either tamoxifen or an LHRH agonist, and tamoxifen or an LHRH agonist plus exemestane. If they received tamoxifen, either with or without an LHRH agonist, at the time of the end of the 5 years, an evaluation is done to ascertain whether they are considered premenopausal still or now postmenopausal. If they have had, an oophorectomy or have, become into a postmenopausal age, say 55 years of age or older, or they had had antecedent chemotherapy and they stopped tamoxifen and reached steady state off of tamoxifen, and their FSH and estradiol levels were in the postmenopausal range, then the NCCN and ASCO guidelines recommend switching the patients over to treatment with an aromatase inhibitor for up to 5 years, particularly if they are high risk. If they are still premenopausal, the ASCO and NCCN guidelines recommend continuing on the tamoxifen for a total of 10 years of therapy. They do not recommend continuing the LHRH agonist. There are no data that going beyond 5 years of an LHRH agonist is of benefit to patients. If patients are very high risk, however, they likely would have been treated from the beginning with an LHRH agonist plus an aromatase inhibitor. And there are no data, there are no clinical trials that tell us that in premenopausal women that going beyond 5 years of that therapy is of benefit to them. We do know that the ASCO and NCCN guidelines do recommend 10 years of endocrine therapy for postmenopausal women with node positive disease. They do recommend 10 years of aromatase inhibitor therapy. So that's in the postmenopausal group. So it's not unreasonable to think that that may also be of benefit in the premenopausal patient with node positive disease. But the national guidelines just speak at this time to an LHRH agonist plus an aromatase inhibitor for 5 years. So in my practice, if patients have very high risk disease, however, and have finished childbearing, if they have multiple nodes positive, I will talk to them over time once they've adjusted to an LHRH agonist. We'll talk about undergoing a BSO at some point in order to render them postmenopausal and then give them a total of 10 years of aromatase inhibitor therapy. But that is an area that's considered a gray zone that really is quite data-free at this time. So it's very, very important in premenopausal patients with estrogen receptor positive breast cancer to optimize endocrine therapy. For the vast majority of patients, that is by far and away the most important therapy for them is endocrine therapy.